Good morning, sir.
Good morning, Nimesh. Am I audible, Nimesh?
Hello.
Hello. Hello. Govind.
Sir, you are audible.
Govind. Hello. Hello.
Hello, morning sir.
हाँ मॉर्निंग.
सर थोड़ी प्रॉब्लम है सर, यहाँ पे एक्चुअली इलेक्ट्रिसिटी नहीं है अभी, अपने डिपार्टमेंट में आ रही नहीं है, प्रॉब्लम नहीं आ रही
अच्छा
सर.
अच्छा तो अपन शुरू नहीं कर सकते अभी.
तो सर सोच रहे हैं प्रेजेंटेशन तो चलेगा नहीं सर.
अच्छा, प्रेजेंटेशन वीडियो से दिखाना था क्या?
सर लैपटॉप पे कर दें.
हाँ श्योर, बिल्कुल परफेक्ट. ठीक है.
बोला नहीं कुछ कैसे सैटेलाइट का कोई ना पता करो कब तक आएगी. अभी कुछ कमेंट नहीं किया.
तो अपन लोग तो हैं, तो शुरू करवा दो यार.
ओके सर.
हाँ
म्यूट कर.
हाँ शुरू करवा दो.
तुम है ना. यस. तुम म्यूट कर देना जब मैं बोलने लगूं, अभी मैं बोलूंगा.
Good morning. Good morning, everybody. So, after a break, we again starting our classes from SMS Medical College and Hospital. Today we will have general class that will be presented by Dr. Rahul Singh, our first year resident. Now I invite Dr. Rahul Singh to present.
बहुत ज्यादा डिस्टर्बेंस आ रहा है.
Okay, start out.
So good morning to all. The first topic of my panel is the progression of disease after BCG therapy, refining patient selection for neoadjuvant chemotherapy before radical cystectomy. So what was the need of study? While neoadjuvant chemotherapy is recommended prior to radical cystectomy in all patients with muscle-invasive bladder cancer, a large proportion of patients do not receive it on a multitude of reasons. Various efforts and trials are underway to allow us to more appropriately select patients who benefit from neoadjuvant chemotherapy. Non-muscle invasive bladder cancer accounts for 75% of new bladder cancer diagnosis. Progression to muscle invasive is heavily staged and grade dependent, accounting in up to 20% of high-risk patients. The benefits of early radical cystectomy prior to progression to muscle invasive are based on abundant retrospective data suggesting high rates of disease progression and the notable incidence of understaging high-risk non-muscle invasive bladder cancer at the time of radical cystectomy. Most advocate for a risk stratified approach to early radical cystectomy with data supporting benefits in high-grade T1 patients with concomitant carcinoma in situ, lymphovascular invasion, variant histology, prostatic urethral involvement, and or multiple large or recurrent tumors. The rate of pathological upstaging for T1 patients undergoing radical cystectomy is as high as 50%, with up to a third of these patients exhibiting extravascular disease on final pathology. Patients who progress on BCG to muscle invasive, that is muscle invasive cancer, stage progression from PTA, CIS or 1 associated with a poor oncological outcome as compared to de novo muscle invasive bladder cancer. A retrospective study in which review patients who underwent radical cystectomy for CT3 to 3 muscle invasive bladder cancer was from 2005 to 2018 was performed in this particular study. Patient was stratified into high risk, that is lymphovascular invasion, variant histology, hydronephrosis, T3B, versus low risk with that is no risk factors, and progressive muscle invasive bladder cancer. That is the patient treated with at least gives adequate induction BCG who progressed to T3 versus de novo muscle invasive bladder cancer. In this study, we describe oncological outcomes in cohort of patients managed with radical cystectomy for progressive muscle invasive and de novo with and without neoadjuvant chemotherapy to contextualize prognosis in patients managed with contemporary standards of care and investigate whether progressive muscle invasive status should be considered as a criteria for patients to receive neoadjuvant chemotherapy prior to radical cystectomy. Descriptive statistics and frequency table were used to summarize the data. Pearson chi-square test and Wilson's rank sum test were used to describe the association between the groups and potential risk factors. The Kelvin-Mean product limit method was used to estimate the overall median overall survival, cancer-specific survivals, and recurrence or metastasis-free survival. The results were out of the 800 patients who underwent radical cystectomy, around 20% had progressive muscle and 80% had de novo muscle invasive. 47% of the progressive patients and 87% of de novo patients were treated with a median 4 cycles of neoadjuvant chemotherapy. And the neoadjuvant chemotherapy was cisplatin based. In low-risk patients treated without neoadjuvant chemotherapy, progressive muscle invasive bladder cancer was an independent poor risk factor being associated with a higher rate of pathological upstaging, that is 64% versus 42%, and higher incidence of pathological nodal disease 28% versus 16%, and worse median overall survival compared to the low risk de novo muscle invasive patients. Complete pathological response rate to neoadjuvant chemotherapy for progressive and de novo were 31 and 30% respectively, suggesting similar therapeutic efficacy in the both cohorts. Compared to progressive muscle invasive without neoadjuvant chemotherapy, the rate of complete pathological response was predictably higher in both the neoadjuvant chemotherapy and the receipt of neoadjuvant chemotherapy was the only significant predictor of complete pathological response of multivariate analysis. Progressive muscle invasive patients managed without neoadjuvant chemotherapy exhibited a significantly higher rate of pathological upstaging on multivariate analysis compared to the all other cohorts. After controlling for high-risk preoperative features, progressive muscle invasive bladder cancer without neoadjuvant chemotherapy was independently associated with adverse pathological and oncological outcomes, suggesting an aggressive and infiltrative phenotypes induced by BCG in non-responders. Delay in diagnosis occurred muscle invasive in high-risk disease related to clinical understaging likely contribute to the aggressive progressive muscle invasive phenotype. To conclude, while patients who progress on BCG immunotherapy to muscle invasive exhibited consistently worse oncological outcomes after radical cystectomy, treatment of these patients with neoadjuvant chemotherapy conferred similar pathological response rates and survival as compared to the patient with de novo patients. These data suggest a comparable window of cure exists in BCG responsive patients with contemporary use of neoadjuvant chemotherapy and justify inclusion of progressive muscle invasive bladder cancer is a risk-stratified approach in neoadjuvant patients. Now the take-home message: patients who progress on BCG immunotherapy or muscle invasive exhibit consistent worse oncological outcome. Progressive muscle invasive therapy and managed with radical cystectomy alone. And progressive muscle invasive status should be considered as a criteria for patients to receive neoadjuvant chemotherapy for radical cystectomy. Thank you.
Okay. Thank you. You can unshare your presentation at this time. So we know the guidelines say that neoadjuvant chemotherapy probably given in all patients of muscle invasive bladder tumor, right? So we also know that the survey says that very few urologists actually give neoadjuvant chemotherapy in every patient of localized muscle invasive bladder cancer. And so the objective probably of this paper is how to select these patients in which we need to give neoadjuvant chemotherapy in localized bladder cancer. So I think as the paper says, and the editorial comment also says, that many of these patients of muscle invasive bladder cancer have a different biological and clinical kind of pathophysiology. And these patients need to be differentiated to start with muscle invasive bladder cancer. So the paper probably tells that those who have to begin with a non-muscle invasive and then they progress to the muscle invasive probably have a worse prognosis and they need to be given neoadjuvant chemotherapy rather than the patients who have been initially diagnosed with muscle invasive bladder cancer. But again, there is a paper which says that if these patients are started on neoadjuvant chemotherapy and 3 cycles are given, then probably it delays surgery. And one of the papers say that probably it has more prognostically worse effect rather than a better prognosis in such patients. So again, I think we need to have further studies, more randomized controlled studies with more patients to actually decide that actually it helps or not. So have you gone across any cross references in these patients? And did you see what are the results?
I have gone through. So their studies say that the neoadjuvant chemotherapy given in the recently diagnosed and those who progress have similar results after radical cystectomy. But no separate studies have been done independently on patients who have progressed from BCG non-responder.
Okay. I think we will proceed to the second article now. Yes.
There was a question in chat box, sir.
Yes, yes. Go ahead. Go ahead, Dr. Yes, please.
How these patients should be selected and what was the median follow-up duration in this study? And the second question was, what are the limitations of this paper?
So I think you must have. So Rahul, please go ahead.
Retrospective study in which study was done from 2008 to 18, around 10 years. Data was collected on the patients who underwent radical cystectomy in this particular institute. Median follow-up period was around 1 year, and then the patients were followed.
Right. I think we can go ahead with the second article. Go ahead, Rahul. Share your presentation.
So the next topic is venous leak and erectile dysfunction, an important differential. This journal was published in Journal of Clinical Urology 2019. The introduction: the erectile dysfunction is the persistent inability to attain and maintain an erectile function to permit satisfactory sexual function. It is a common medical problem with an overall prevalence of 52% in men between age 40 to 70 years. Veno-occlusive dysfunction is an important cause of vasculogenic erectile dysfunction. To date, no medical therapy exists for treatment of this condition. While surgical management options are based on the resection or ligation of the offending venous drainage, with a significant decline in the efficacy with a follow-up exceeding 12 months, perhaps as a consequence of collateral drainage. Pathophysiology of the disease. In men with veno-occlusive dysfunction, cavernous smooth muscle damage results in insufficient sinusoidal relaxation and expansion during tumescence, leading to improper closure of emissary veins as the albuginea layers are inadequately compressed. Thus, venous leak ensures and leading to detumescence and erectile dysfunction. Known possible causes of venous leaks are congenital vascular anomalies, trauma, post-priapism, diabetes, and Peyronie's disease. Clinical presentation. The patient with congenital venous leak typically presents with a lifelong inability to achieve a fully erect penis, that is primary erectile dysfunction, under any circumstances, and commonly presents in a younger age group, that is 10 to 12 years. We usually describe any tumescence as inadequate for penetrative intercourse and of short duration. Whereas the early morning and nocturnal erections are similar, weak or absent, but libido is unaffected. Acquired veno-occlusive dysfunction presents in the same way, but is preceded by a traumatic episode, for example, a road traffic accident, post-priapism, etc., and the patient usually offers a history of normal sexual function prior to the index accident. The investigation, the colored Doppler ultrasound with a 7.5 12 MHz probe determined various vascular parameters featured to cavernous arteries, specified time interval, both in the erect and flaccid penis. In this study, in the presence of normal arterial flow, if the peak systolic volume is greater than 30 centimeters per second, the veno-occlusive dysfunction is present if the end diastolic volume is greater than 6, which is normal less than 5, and the corresponding resistive index is less than 0.6. Other investigation, cavernometry and cavernography. It is an invasive test in which a drug, for example, prostaglandin, is injected in the body of penis. Pressure within the corporal bodies are measured before and after injection to determine an objective degree of tumescence. Intravenous contrast can be administered for the evaluation of venous leak. NPT electrobioimpedance aims to assess the 3-dimensional volumetric penile change with tumescence rather than the 2-dimensional assessed with standard NPT. In patients with veno-occlusive dysfunction, NPT assessment reveals a low volumetric change with erection and fewer erectile episodes, although precise definitions have not been determined. Recent trials have also shown that a multi-detected CT scan with intracavernous injection, that is CT cavernosography, were able to differentiate among various venous pathways in men with primary venous origin erectile dysfunction. Now, from the management, there are 3 options: ablation, embolization, and surgery. Ablation, polidocanol, a local anesthetic agent, was used with a success rate of 80%. 50% ethanol has also been used with some success when injected.
No, this all should not be discussed inside a journal presentation, Mother. What you are discussing is, I mean, you should come to the crux of what the study was and what your results were. I mean, this is all taught inside a seminar. You don't have to go into the introduction, the results which were done, and these are not.
So let him go, and you can just come to the point. Slide, right?
So the main mode of treatment was surgery, in which the ligation of deep dorsal vein of the penis offered an early 3-month success rate between 66 to 70%, with only marginal decline at 12 months. The failure was thought to arise from persistent leakage, perhaps previously undetected, from the crural cavernous and bulbourethral veins. Ligation of the penile vein immediately following its formation by the merger of bulbourethral and cavernous vein is in the range of reported success between 24 to 63% at 12 months. The complications of veno-occlusive surgery, main complication was penile shortness. To conclude, the veno-occlusive dysfunction is an important cause of vasculogenic erectile dysfunction. Investigations are hindered by the inability to account for varying degree of arterial insufficiency and the potential presence of minor but still significant venous leaks, site undetectable in the presence of greater leak. Effective management options are based on the resection or ligation of offending venous drainage with significant decline in efficacy in follow-up 12 months, perhaps as a consequence of collateral damage. The limitations were the study relied on patients' report of sexual functioning rather than
issue jaan se jana beta.
to show subjective improvement or change in the quality of life. The take-home message: the veno-occlusive dysfunction results AD remains an under-researched with a poor quality evidence base. While it's undoubtedly a definitive clinical entity, there remains a significant number of unanswered questions at all stages of patient pathway. While it's an attempt at diagnostic standardization has been made, reliable reproducibility is yet to be achieved at 2 etiology infection even elusive. Effective management options are based on the resection ligation of ending venous drainage.
Yeah. So you can unshare your presentation now. Mute yourself. So definitely venous leak is still a dilemma, and whether surgery is required in venous leak erectile dysfunction again remains very controversial till date. So I had requested a few comments from one of few stalwarts in this field of erectile dysfunction, and I received some comments from one very promising upcoming andrologist, Dr. Pramod Krishnappa from Bangalore, who is a senior consultant at New Hospital there. So he writes that the two major hurdles in venous leak is one is the improper diagnosis, and the other is the ineffective treatment, which we all know. The results are very poor, and even if they are transient, and not long-term result success rate is very poor. And so he has cited one of the articles which says the variation in penile hemodynamics by anatomic location of cavernosal artery imaging by penile Doppler. This was published in just recently. And then he says that no imaging can actually capture venous leak effectively. And the presence of a radiologist or an attached device is enough to make him conscious and bring down his erections, leading to a false report of venous leak. So this is very important for all the residents and the young urologists to know that what you get in the report of a penile Doppler study as venous leak actually may not be true venous leak. And they may be actually due to the anxiety and all that, which results in cavernosal smooth muscle contraction, and which actually falsely shows as venous leak in the penile Doppler report. So he goes on to say that today's paper has all references which are mentioned in the management section are from the studies which are done before 2000. And so nothing new has evolved in the venous leak management. And the interventional radiologists publish about embolization, and urologists place penile implants. So that's the usual treatment that we are going through now. And differentiating congenital versus acquired venous leak theoretically may be easy, but practically is not so. My personal opinion is that some of these patients who have primary erectile dysfunction, that means they since beginning, they are not having erection since their adolescent period. And if you diagnose them as a primary venous leak, probably they are the only candidates for venous leak surgery. And that is not very common. So a majority of venous leak surgery, venous problem is probably the acquired causes. And Dr. Pramod says that the scope for research is there, and one of the articles that he has cited was also cited by Dr. Rahul, that was computed tomography, cavernosography combined with volume rendering to observe venous leakage in young patients with erectile dysfunction. And he has also cited the erectile dysfunction AUA guidelines, which is very categorical in saying that for men with ED, penile venous surgery is not recommended. So it's a moderate recommendation with evidence level grade C. So this is very categorical on guidelines, and the personal opinion of Dr. Pramod is that he would prefer to do a penile implant surgery than venous ligation in a venous leak. And because the problem is not only at the vein, but also the non-compliant and non-yielding corpora cavernosal tissue, and sometimes even the tunica albuginea. So the collaterals usually develop after venous ligation. So ED recurs after a few months. So this was my personal opinion is that yes, most of these venous leak surgeries would not work. And if you have primary erectile dysfunction with venous leak, then you should do a very aggressive venous leak surgery in which you have to excise the whole dorsal vein. You ligate all the branches of the dorsal vein. You go up to the cavernosal veins and then ligate the cavernosal veins and even plicate the two crural bodies. I remember we had done a couple of cases with these, and one of them had a good result. Those patients were of primary erectile dysfunction, where we had ligated the crura with umbilical tape. And studies have also shown that. Again, I have one more comment from one of the, I think you can call the father of andrology in our country, Dr. Rupin Shah. So he has sent his voice comment. So I will just put this voice comment in front of you.
Hi, Shivam. In my experience, most cases, almost 95% cases of venous leak diagnosed in our country are wrongly diagnosed because of an incorrectly done penile color Doppler. The cavernosal smooth muscle is not relaxed at the time of the Doppler. The penis will still be in a physiological state of venous leak, and that is what will show up. Since almost all sonologists use only papaverine for the penile color Doppler, that is quite inadequate in overcoming high levels of anxiety-induced cavernosal contraction. And this has also been documented and published by other authors, showing that young men with venous leak, after being reassured, counseled, made relaxed, and repeat studies were normal. So I see an epidemic of venous leak coming to my clinic for second opinions, and the vast majority of them are normal.
Thank you, Dr. Rupin, for that voice comment. I just had called him yesterday night only, and he was very gracious enough to give us his comments on this particular. So this is all about the venous leak surgery, and I think a very important topic because it is very controversial still. And if you do venous leak surgery in these patients, and often these do not work. So I again request Dr. Rahul to kindly share his presentation for the third article. We are not able to see your presentation. Yes.
This was published in Journal of Clinical Urology 2020. Introduction: hypospadias is the most common congenital exongenital anomaly affecting one about 300 live births globally. It is a hyperplasia of ventral penile tissue beyond the division of corpus spongiosum with abnormal meatus position and penile ventral deviation and or ventral prepuce defect with abundant dorsal pit. Only 10% of the cases occurred posteriorly the scrotum or perineum, while distal and coronal or subcoronal type are the most common. Single-stage urethroplasty can be used for the anterior to posterior hypospadiasis, developed from a simple technique by epispadiasis by Carl Frisch in the 19th century. Angara Dublé used tubularization for hypospadiasis repair utilizing urethral plate and ventral penile scale to perform the urethral tube. Duckett popularized the one-stage transverse tubularized preputial iron flap technique intended for severe body hypospadias with long urethral defects. In 19, Snodgrass introduced TIP urethroplasty for severe hypospadiasis. Coagny et al. Pioneered the use of meatal base, meatal wing, and parameatal base flap with circumscribed foreskin flap urethroplasty in a single-stage fashion. Is the most common complication of urethroplasty, followed by meatal stenosis, urethral stricture, or diverticulum, glans dehiscence, and a poor cosmetic profile requiring redo surgery. This study aimed to describe our current experience with single-stage urethroplasty and to determine several preoperative factors associated with the use of fistula. It included all hypospadiasis patients without any prior urethroplasty history who underwent single-stage urethroplasty conducted in Cipto Mangunkusumi General Hospital, the National Referral Hospital, Indonesia, between period of July 2010 and January 2018. Patients were followed for at least 1 year post-operatively. Demographic data, information on the type of hypospadias, preoperative urine leukocyte count, operation technique, chordae degree, urethral length, defect, and UC fistula occurrence were collected. The type of hypospadias were classified based on the preoperative urethral orifice location using the classification one described by Dr. in 1996. 3 classifications were used, that is anterior granular subchoroidal distal shaft, middle shaft, proximal shaft, and posterior penoscrotal scrotal peri. Penile cardio ventral curvature was assessed preoperative and classified mild, moderate, and severe. After cardiac excision and penile curvature correction, urethral length defect was measured. The urinalysis was routinely performed preoperatively at our institution to determine the need of early empiric antibiotic therapy. Urethroplasty technique. The urethroplasty technique used varied according to the surgeon's preference based on the preoperative assessment and intraoperative findings, the latter being the paramount factor. 3 independent pediatric urologists performed surgery at our institution. After the cardiac excision, penile curvature was assessed to determine the need of further intervention. Penile curvature of more than 30 to 40 degree after cardiac excision warrants dorsal shortening, that is Baskin's or Nesbitt's dorsal plication, with preserved urethral plate techniques, TIP, Thisch, Duplay, Matthew, and others, or even ventral lengthening with transected urethral plate technique. Most urethral tubulization were done using 60 PDS and short 6 French elastic stents, 5 to 6 cm, depending on the tubulization band. These elastic stents was fixed to the glands using 30 proline suture. For the older patient, 50 PDS and 10 to 12 French silicone Foley's catheter were used. Urine diversion during cystostomy was used for all urethroplasty technique involving neourethral tubularization. Post-operatively, the wound was treated using antibiotic dressing that is fixed using elastomole for up to 5 to 7 days and treated with chlorophenicol ointment. The elastic stent of silicone catheter was removed after 5 to 7 days, while the cystostomy was kept in place for around 14 days. Data collection. Data was collected through medical records, phone survey, and messaging system survey. UC fistula was chosen as the main outcome since it is the most readily recognizable by both patients and doctors, did not require an additional examination. Statistical analysis. Data was collected using IBPM SPSS system of window. All categorical data was analyzed using chi-square test, while numerical data was analyzed using an unpaired t-test and man with a u-test, and p-value less than 0.05 was considered significant. The results. A total of 179 patients were included in this study with a mean follow-up around 47 plus minus 28 months. Posterior hypospadiasis, for the surprise, was found to be the most common encountered predominant penoscrotal cases with severe chordae. Preoperative leukocyturia was found in around 7% cases. Only percussion lining flap were the most versatile single-stage urethroplasty techniques at our institution of around 40%, followed by TIP and ducket. Only percussion island flap and TIP were most suited for anterior, middle, as compared to posterior hypospadias with low fistula rate, respectively. UC fistula occurred around 13% cases, with most happening in the first month after surgery. The fistula rate was quite similar between the TIP, only island flap, ducket, and Thisch urethroplasty. The higher fistula rates occur in Quagny and Matthew urethroplasty groups. The limitations of retrospective studies might pose selection bias, and most patients in this study might have educational and economic limitations which contribute to the poor treatment compliance. Conclude, single-stage urethroplasty versatile procedure for various hypospadiasis with an overall UC fistula rate of 13%. Posterior hypospadiasis, preoperative pyuria, and a longer urethral defect was associated with UC fistula formation.
Thank you, Rahul. Again, a very, I think, important topic that we are discussing now, because hypospadias surgery, we all know, has a very high complication rate. And in spite of having so many types of surgeries, I think that is numbering more than 200 or 300 types of surgeries for hypospadias, we still have not come to that point where we can actually give these patients a very good success rate. And the complication rate is as high as 50% in many of these studies, which includes definitely urethrocuteneous fistula, meatal stenosis, urethral stricture, diverticulum, and all these complications. And when we talk about urethrocuteneous fistula, again, the complication rate is quite high. On an average, most of the studies show about 10 to 20% complication rate. And though some of the studies have less than 1% complication rate, there are 1 or 2 studies like that. And but again, there are studies which show about 30 to 40% urethrocuteneous fistula rate. So we have still not been able to overcome this complication in hypospadias. We all know that the most important, probably, to prevent fistula after hypospadias surgery is a good surgery, technically good surgery, where the technique is very good when you go actually into the planes and do not injure the vessels and create the best urethral tube with a kind of interposition tissue in between the skin and the tube. And then again, a proper hemostasis is again very important, because the hematoma formation can lead to infection, and again can give rise to fistula formation. And again, if you do not have a good, if the patient develops infection after the surgery due to some reason, as in this case, definitely patients with preoperative pyuria had more chance of urethrocuteneous fistula formation. So infection is again one of the very important factor for development of urethrocuteneous fistula. We have various studies again, which besides these factors, they discuss on the suture material being used. And most of the studies show that suture material and type of suturing probably doesn't matter. Whether you take a through and through suture or a subcuticular suture or an interrupter or a continuous suturing, all these probably doesn't matter, even the type of suture. Some have used catgut, some PDS, some bicryl suture. But definitely the fine suture has the best results. So you should use a 6-0 or 8-0 suture in these patients. Again, some of the studies have even shown that those patients who have been managed later, in the later part of their life, like above 6 years, the results are poorer. And these studies say that the results are poorer because these patients have frequent erections. And these frequent erections that can probably cause fistula formation later, or some of these patients, because they develop a kind of a skin flora which is not conducive and more conducive for infection post-operatively. So they have more chances of developing infection and then urethrocuteneous fistula. Again, there have been a study like that those patients who have been given a caudal block had more chances of fistula formation. Again, in that study, they said that it is due to caudal block produces a penile edema, and that penile edema results in probably breakage of the suture, and that results in kind of fistula formation. The type of surgery, whether it's a tip repair or a flap repair, again, some of the studies says that yes, if the type is like in one of the studies, they said that the Matthews flap in distal hypospadias probably produces less stricture formation than a tip repair, and they may have a better result. But again, it depends upon the surgeon's experience. And again, the duration of the surgery is important. If the duration is more, then there's more chance of probably infection and resulting in this. And one of the studies interestingly said about the infiltration of saline mixed with adrenaline. So most of us usually put this infiltrate under the skin before doing this surgery. And they have said they have had poorer results when they had infiltrated adrenaline. And this probably is because that this adrenaline produces a subcutaneous wound oxygen tension, which jeopardizes the tissue healing. And it has also been shown that adrenaline causes a negative effect on macrophages. And because these macrophages actually cannot engulf these leukocytes, which may be present post surgery, and they may lead to infection. So these were some. So I would request if any of the faculty member has any comment to make on this article, please go ahead. Before I wrap up by the comment from one of the stalwarts in hypospadias surgery. So Nachiket, do you have any comment on this?
Sir,
Yes, go ahead, Nachiket.
Sir, no, sir, I
So
think
you are
that
not audible.
Nachiket, you are not audible. So before Nachiket comes, I will just read out a comment which I have got from Dr. Mukesh Arya. We know Mukesh Arya is a principal and a professor head of the department at Bikaner Medical College. And he has been doing a lot of hypospadias surgery. And he comments that almost all types of hypospadias can be repaired in one stage. And longer the tube, higher the fistula rate. Again, this is also highlighted by our article that the urethral defect, if it is longer for the repair, there is higher chance of fistula rate. And he also says that preoperative urine culture should ensure sterile urine, and dissection in the proper plane, proper hemostasis, use of suture material, and use of multiple barrier layers are paramount in reducing fistula rate. And in all cases where feasible, I dissect bifurcated corpus spongiosum and do a spongioplasty. Again, a very important point brought out, that if you do a good spongioplasty, it might probably reduce the fistula rate and gives strength to reconstructed tube. Almost in all cases, except distal penile hypospadias, and in all redo cases, I use tunica vaginalis as a blanket wrap apart from ventral dartos, which reduces the fistula rate markedly. So multiple ventral corporotomies using ophthalmic blade helps to correct the chordae and do surgery in one stage despite chordae more than 30 degrees. I personally have no experience of suprapubic diversion. So thank you, Dr. Mukesh, for those comments. And yes, a very good point brought out is about the suprapubic diversion. There are various studies which show that putting a suprapubic diversion, particularly in proximal hypospadias patients, might help to reduce the complications. And again, spongioplasty could be a very good thing to do if you have a good spongiosum tissue to wrap up the reconstructed urethra. And definitely the barrier in between the urethral tube and the skin is again a very important part of the surgery to reduce the complication. So Nachiket, are you there? Would you like to comment? Any other faculty member, if has anything to say, please go ahead. Otherwise, we will wrap up this session. This was our beginning after probably a lull for about 1 month because we had MCH examinations of our third-year students, and we have started again our teaching class. And this is again a hybrid class. So we are having physical presence of the residents and faculty. Unfortunately, today we had a load shedding, electricity off, so we could not actually show you our class and everything, but definitely we will be doing it in our next class. So, so if nobody has anything to say, then I would request our moderator today, Dr. Govind Sharma, to give a vote of thanks and wrap up the session. So please, Dr. Govind.
Thank you, sir. Thank you, Rahul.
Dr. Govind, I think on mute.
So thank you, all of you, all the residents, all the faculty members, not only from Department of Urology, SMS Medical College, but also those who could have joined us from various parts of the country and various medical colleges, because this teaching session is being transmitted on Zoom plus YouTube also. So again, thank you very much, and see you tomorrow. Thank you.
Thank you, sir. Thank you, Rahul.